welcome to the Pod Doctors. I'm Dr. Damien Dauphinee, and I'm here with my partner,
Dr. Raafae Hussain.
And today, we're going to talk about the scourge of athlete's foot.
Oh yes, the old itchy foot. So let's just dive right in. Athlete's foot, very, very, very common. I mean, I think the studies show that like 1 in 4 persons has some type of fungal infection, commonly athlete's foot or fungal toenails. I mean, ultra common. So, I mean, what do you typically see? You see the patient come in, itching feet. They got these scaly lesions, sometimes between the toes, sometimes on the bottom of their feet. They don't know what's going on. They think they got, I don't know, like typhoid or
some people crazy. Don't get the itching, but they have that flaky, dry skin in the moccasin distribution, as we like to say, wherever a moccasin would be touching you. They think it's just dry skin.
I feel like that's so common in the diabetics, especially when the ones with the neuropathy.
Because they can't feel it. Yeah.
Right. Yeah. So, I mean, what we're looking at when we look at these, we see that scaly annular lesions, moccasin distribution. So moccasin distribution is a fancy way of saying that imagine a moccasin on your foot. It's literally all the areas on the bottom of your foot and that little, I don't know.
Transition skin, yeah.
Yeah, exactly. That goes around the foot and not so much on the top of the foot as often.
Except the top between the toes. Sometimes you'll see it kind of spread out.
Yeah. So here are some pictures, and there's different versions that we'll see. Interdigital, probably the most common that we see. It's funguses like moist, clammy, cool environments between your toes. You hold that moisture, your feet sweat, you're in closed-toed shoes all the time. It just happens.
And you see that bottom left picture with the fissures.
Yeah.
There's tinea in all those cracks, I'm sure. Yeah. But that's also something called raggedy xerosis.
Yeah. Ultra painful.
Yeah.
Very tender.
That can be tough to treat. So we've got some cocktails that we'll use, topical cocktails of multiple medications that can help break that down, allow those fissures to heal, and greatly improve the appearance and texture of that aspect of the foot.
Yeah, and here's a good example when we're saying moccasin distribution.
Yeah.
You see how it comes up just along the sides of the foot, but not so much on the top. Here you can kind of see the pustular style, the bullous.
That hurts.
Yeah.
Yeah.
So here we go. So 3 types. Interdigital, most commonly between the 4th and 5th toes, but it can be anywhere interdigital. That moisture retention, like we said, fungus is like that cold, clammy, moist environment. The hyperkeratotic, that's the ones that most people don't realize that they have fungus. Mm-hmm. They have athlete's foot. They have, I got some calluses, I got some scalies, nothing that a little, pumice stone and some cream, won't fix. But it's really athlete's foot. And then the most irritating is the vesicular, the pustular, whatever you want to call it, the athlete's foot. And that's when people are like, I think I got some type of infection going on. And that's when people come in that are more concerned about their problems. They're like, it's just been like this for a few weeks now. It's just getting worse and worse and worse. It's so itchy. It's popping bubbles. It's clear to like whitish drainage. And we're super concerned. We don't know what's going on. But this is a good picture of what you can see as it's a wide picture of what it can and can't be.
Right.
So I put in some differentials.
And you got multiple organisms that are causing this. So that's the other thing is there's different trichophyte and metegrophytes, trichophyte and rubrum. There's multiple that are sort of endemic to this part of the world, and they're literally everywhere. And so, a lot of this has to do with whether your immune system can fight it off. And some people just don't have that capability, so they get this over and over and over.
So because it's so similar to a lot of things visually, I put a little differential diagnosis, see if you guys can kind of follow along. So here we see the interdigital maceration. You can see that moisture, the aggravation. And then when we use our Woods light, that UV light, we see some coral red fluorescence coming off of there. So buzzword being coral red, if you guys are studying for your boards, that is erythrasma.
Yeah.
Semitismum, very itchy, very, common. And we use our, erythromycin or whatever plagiates to take care of that. I guess you can pretty much use anything that's antiseptic. Iodine, hydrofluoric.
I think one of the things that we used for that for the most was the topical erythromycin, but also topical Clinda.
Topical Clinda.
Yeah.
Yeah, I know that back in the day, people used to use that the gentian violet. Paint your toes. It almost looks like you went blueberry smashing.
Yeah.
You know? Or
Purple.
it looks funny. Here's another one.
Ouch.
So
that looks no fun.
Patient comes in, very tender. They got blisters and stuff going on. But take a good look at that. You can see that it's almost mirrored on both feet. So
I would worry about the, topical hypersensitivity to something. Yeah.
Well, contact dermatitis.
Yeah, contact dermatitis, exactly.
So we'll use, like, all right, whatever you've been wearing, new sandals, new socks, stop using them, go back to your basics, and then we'll use like a topical steroid to help calm things down. But yeah, you can see how it almost looks like the pustular style of tinea pedis or athlete's foot. Here's a very common one. So scaly, tender, flaky. Sometimes you can get some fissures and bleeding.
The pitting in the nails.
Pitting in the nails. That's your buzzword right there.
That's the key to diagnosing this one.
So a little psoriasis going on there. And that's when you're like, all right, you have to use antifungals per se, because if they don't have a fungal problem. But we do need to use topical steroids and other things like that.
When it's this bad, sometimes, they start looking at Humira and some of the other, big gun.
Immunosuppressant type things.
Yeah, exactly.
And this is also another reason that sometimes we'll take some scrapings and we'll send them off. Because if it does look similar and we're like, hey, this might be this, or might be that, or it might be both.
You could have psoriasis and then tinea literally irritating all those little cracks.
Yeah.
So, yeah, absolutely.
Here's the last one. We've got the little pustules, the little dots on the feet. I put this picture in specifically because of the tracking of the lesions. So that's when we're thinking something along the lines of scabies. We had a scabies scare in my old office. We had to literally bug bomb the entire place because it was a patient came in and had scabies, and then when the patient left, we cleaned the rooms and we saw them on the floor, like so much that that it was definitely on their clothes. And yeah, we had a bug bomb the place, and
yikes.
Yep. Luckily, it was on a Friday, so we
bug bomb the weekend.
Yeah, but yeah, you don't want that.
Yeah.
I'd rather have athlete's foot. All right, so here. Oh, this is what I was reading from the Defense Health Agency, that up to 25% of the global population is affected by tinea pedis at any given time. And obviously, athlete's foot and the dermatophytes are the most common type of infection amongst adults. We know that.
Yep.
So pathology, what happens? So tinea is a fungus. Most commonly it's T. rubrum. I think it's like 70% of the time. Most studies show 70-80% of the time. And it gets into the superficial layers of your epidermis, and it sits there and it eats all the healthy skin or the dead skin cells, and that's how it grows. It's food for that fungus to grow. And while it's there, it's obviously causing itching, rashing, tenderness, flaking of the skin, all the symptoms that we see superficially. Treatment is a process. We usually start off with basic things. We'll do the scrapings if needed, if we're concerned, but we'll start off with the topicals. And let's start off with the home remedies before we even get into the topicals, because I know there's a lot of them out there. Some of them, and they do work. Some of them do work, and we'll go through some of the logic why it works. I mean, obviously the antifungals are more specific to the problem. They work better, but let's talk about Listerine is a classic. Listerine and some water, sit your feet in the tub, let it soak for 15-20 minutes. And the logic is Listerine, it kills 99% of germs or bacteria. But Listerine is an alcohol. It's a pH change. The funguses can't tolerate that pH change, and that's how they die. That's the same logic with the apple cider vinegar. That pH change, the funguses just can't tolerate it. Now, are there things better than that? For sure.
Yeah.
But if you want to use this as an adjunct, or start off with this, and if this doesn't work,
or maybe even as a preventative.
Yeah.
You don't have an active case now, and you want to keep it under control because you've had it in the past.
Yeah. If kids that go to the locker rooms all the time, or the swim classes and stuff. My kids are in swim classes right now. I check their feet all the time because I'm like, one of these days they're gonna get some type of little skin infection. Those locker rooms are just a nidus for bacteria.
Sure. So that's where I think the tea tree oil, is not a bad.
Oh yeah,
adjunct.
I love tea tree oil for these
as a prevention.
Yeah, nails and skin, it works great. And the logic with the tea tree oil is antimicrobial to an extent, but what it really does, it's an oil. Funguses just can't grow in oils. If you keep the skin oiled up with any type of oil, it'll work. That's why garlic oil, I've heard argan or oregano oil. I don't know. There's a bunch of them. You can use castor oil if you wanted to use canola oil. It wouldn't be the most clean, but I mean, it would help out. And the last ones are like the baking soda, the starches, and the tea soaks. What they're really doing is literally just wicking the moisture out of the feet. Funguses want that cold, clammy, moist environment.
The tea soaks also supposedly, if you're doing that with like black tea that's brewed far denser than you would drink,
the hyperhidrosis.
Yeah, you're getting an acidic response that's shutting down the sweat gland. Yep. So you're and there's something to that.
Yeah,
I think dry sol works better.
Yeah.
But if you want to go that route.
Yeah, these are all home remedies. They do have some bit of truth to them, and that's why we bring them up. There's other home remedies that we can talk about. Acai berry isn't going to fix this. Turmeric isn't going to fix this. But these certain things, yes, they have a place. But there's things that are better. Topicals, we almost always start with topicals. I am a big fan of the foams, the gels, and the liquids. The powders are decent. The powders work well. I think if you use them in conjunction, they work great. The only downside of the creams and the ointments are that the creams and ointments push for more moisture. Although they has some level of antifungal, mixed in, terbinafine, clotrimazole, meconazole, econazole, all the conazoles and whatnots. They all work, but if you add the moisture component to it, you're just going to hold more moisture there. So that's why I like the foams, the pledgets, the liquids, the soaps.
And the old adage, though, that if it's if it's dry, you want to wet it. If it's wet, you want to dry it. So you can kind of play with, is this a real soupy tinea where their hyperhidrosis is going nuts? You kind of got to address both.
Yeah.
So being able to find something that's going to dry things out, maybe stick with the powders.
Yeah.
But that's kind of the way I usually approach it.
Now, when it becomes, uncontrolled, or if it's worse than your baseline athlete's foot, we might go to a combination of the topicals plus an oral. I mean, very rarely do I ever have to get to it, but if I see it's been long-standing, we might jump on the train. Terbinafine and itraconazole are the go-tos, but we use them very sparingly. Athlete's foot is easily controlled if you do your baseline therapies. The only downside is, if it doesn't get better, we add the pills, we get some blood work done, and it should be fine. There are some things that I do recommend to use as an adjunct, regardless of what level of athlete's foot you have. Simple things, moisture control, like Dr. D said, the powders, the odor eater moisture control powders, they work so well. Yes, it will be messy, and that's why I usually say, all right, start off with the powders, and then once things get better, maybe go to like the moisture control insoles, the odor eater insoles. They work great. If you're in closed-toed shoes, leather shoes, boots, construction boots, if you're in sneakers and you're sweating, or if you have hyperhidrosis, your feet sweat quite a bit, you just got to stay ahead of it.
Change your shoes often.
Yeah, breathable socks. A lot of people have been wearing like the synthetic socks, which don't breathe as well as cotton socks, supposedly. I don't know.
Well, there's some evidence maybe to support the fact that the acrylic socks like Thorlo help wick the moisture away and let it evaporate out. So, I mean, there is some truth to that. Some people just prefer the cotton, but the cotton does absorb moisture and hold it next to your skin, and that can be a problem for blistering. It can be a problem. But I like the acrylic socks for folks that I mean, I think there's something to it. But if they're wearing the acrylic socks in a leather boot, it's got nowhere to go. It's harder for it to evaporate out. But if you're wearing the acrylic socks with the mesh running shoes, it does help, I think, wick that moisture out and let it evaporate.
Doing a Lysol sweep or an antifungal spray sweep of your shoes, your slippers, your moccasins, your bathtub, anywhere that's going to hold that fungus there. Simple way to make sure that you don't reinfect yourself. Sometimes we'll be killing it on the skin surface, but they'll just keep on reinfecting themselves with their whatever UGG boots or like their construction boots or whatever that they're wearing. You can do the antifungal sprays, or you can do the Lysol, or what's newer,
light therapy,
or the UV lights. They kill everything that they can put their light onto. They work well, but it's simple things, and these are adjuncts. These aren't going to cure the problem, but these are going to help make sure that once the problem is cured, it won't come back. But I mean, that's far as things go. Athlete's foot's very, very straightforward. All we got to do is just get ahead of it. Easier said than done, but once we get the therapy going, it really does get better fairly quickly.
And then I think a prevention protocol is important. So if you see somebody who seems to get it routinely, it's got to have something to do with their immune system's inability to fight this off.
Yeah.
Just accept that fact and treat it like you would any other chronic health condition like high blood pressure. I have high blood pressure. If I don't take my blood pressure medication, what do I get? My blood pressure goes up. I get tinnitus. I get headaches. So I have to control it chronically. If I had problems with athlete's foot over and over and over, I would want to be on some sort of prevention protocol, and that would mean using a topical, let's say twice a month.
Yeah,
every couple of
weeks.
Just
to stay ahead of it.
Yeah, just to stay ahead of it. Hose down the shoes with the Lysol or with, we have a product called Clean Sweep, which is very similar. It's just an spray.
It's an antifungal spray, antimicrobial spray.
So that, does a good job of just lowering the load of these microbes that you're coming in contact with and can help prevent infection. So we're all coming in contact with this stuff. It's ubiquitous. This stuff is everywhere. Yeah. It's just a matter of whether or not it hits you at the right time. It's an opportunistic infection. If you let your skin get scaly and dry, that's an open invitation for viruses and bacteria and fungus to get in there and set up shop.
And it can spread from person to person. If you're, your mom's got it and you're wearing the same flip-flops as her, it can spread. It's anthropophilic. It jumps from human to human.
Got that nice
anthropophilic.
$5 word in there.
But yeah, and that's pretty much it for athlete's foot. It's a very straightforward problem, and we offer very straightforward solutions.
Absolutely. Very nice. Well, that was a quick and easy one. Thanks, Dr. Hussain, for putting that together. And we will hopefully see you guys next time on the Pod Doctors.